Well, thank you all for coming back after lunch. Going to talk about the COVID-19 pandemic, and the subtitle of this is When Scientists Abandon Science. We've had a couple of questions over the last 2 days about trust in science, and to me, unfortunately, the pandemic has probably set us back many decades and led to deep distrust. We've only seen, I think, the tip of the iceberg. So I'm going to walk you through some things from the pandemic, some considerations. And who am I? Of course, just as background, I'm a professor in epidemiology and biostatistics at the University of California, San Francisco, and I'm a practicing hemonc doctor, just like John. See everything from benign hematology to rectal cancer. I work in clinic in the hospital. And I teach several classes and run a research laboratory. Okay. So I think one of the main points I want to make of this talk, there are two concurrent themes. One is on a number of important questions around the pandemic, scientists did not express uncertainty adequately. We took drastic actions. We extolled those actions. We didn't express the underlying uncertainty. That went hand in hand with we didn't permit or foster debate. The debate was actively squelched and prevented on social media channels and even at universities. I cannot think of any debate at any of the premier US universities, Harvard, Stanford, Johns Hopkins, University of California, San Francisco, on whether or not we should have closed elementary schools. We went the entire pandemic. We made one of the biggest health policy decisions of the last century, closing elementary schools in my city of San Francisco for 18 months. That was never debated at any university in America. How could that be? We didn't run studies to reduce uncertainty. We did so many things. We didn't study it at all. We have no clue about community masking, leaving the pandemic, then we entered the pandemic. We have one study from Denmark, DanMask. It has some limitations. We have a Bangladesh study I'm going to show you that has riddled with limitations, and a study in the Guinea-Bissau that's not been published. But in Europe, there were no studies in the Netherlands. There were no studies in America. No cluster randomized trials of 3 feet versus 6 feet distancing. No trials of school closure. No trials of school reopening. There were proposals in Norway. We didn't do anything to reduce uncertainty for non-pharmacologic interventions. We did a poor job even for pharmacologic interventions. We have many pharmacologic interventions we use in 2023 that have no credible evidence. Paxlovid is one. It has never had a positive study in people who have received the vaccine, and yet it is widespread in America, being prescribed every day. And then I think the establishment view, the view that was pushed by scientific authorities, was incorrect, and not only in retrospect, but at the time. I think that a lot of the reasons why we got the pandemic policy wrong was because we were fearful, we lacked principles, particularly scientific principles, we were ignorant, or worse. We turned scientific questions into political questions, particularly in the United States. The second theme of this talk, I think, if we have time to cover it, is that academic freedom and censorship to science and scientists are threats to universities and beyond. We had both active violations of academic freedom, where people were told to not publish articles, to have articles stripped from servers. I'll show you some of that. And we've had passive violations of freedom where debates were not held. If you don't have a debate on whether or not kids should mask, then it is a type of censorship in my mind. In the United States, the American Academy of Pediatrics and the CDC recommended that kids who were 25 months old wear a cloth mask in daycare for up to 12 hours, except for when they nap. That policy was implemented at the federal level and mandated in Head Start programs, and you could have children thrown out of school if they didn't comply. You had families pulled off airplanes for non-compliant 3-year-olds. That was the power of the state enforcing a public health intervention that has no credible evidence and doesn't really make any sense, even without evidence. And that is a type of, I think, a deep problem that we weren't able to debate that. Okay, so let me walk through some of these things. I don't want to talk about everything. I think it's impossible. I think some of the hardest things to talk about are lockdown, school closure. School closure, I think I won't waste too much time on because I think increasingly people realize that was a great mistake, particularly school closure around elementary school kids. In Europe, in places like Switzerland, they closed for 6 weeks. In the United States, in Los Angeles, in DC, in Chicago, in San Francisco, we had school closure from 5 years to 18 years old for 18 months. They were out of school. It's a generation of kids who will be lost, and they're going to have diminished health outcomes as a result of that. Let me talk about hospital visitor policies, delaying the vaccine's initial approval, vaccine mandates, and this perpetual booster campaign in the time I have with you. Hospital visitor policies. This was a paper we published in the American Journal of Medicine. It's called The Effect of Hospital Visitor Policies on Patients, Their Visitors, Healthcare Providers During the COVID-19 Pandemic, a Systematic Review. Here are some of the things we did in America, perhaps even in your country. We prevented parents from seeing their children who were dying of cancer in the hospital. They could only come one at a time. So the mother and father could not be present with the child who was dying of leukemia. This was a COVID mitigation effort. It has no credible evidence as far as I can tell. I'm not sure this policy prevented one case of COVID-19. If a child who was 6 years old was dying of leukemia in the hospital and their brother was 10 years old, that brother was never allowed to see that dying child. This was an American policy. We prevented adult children from holding the hand of their dying father or mother in the peak of the pandemic. And that policy continued even into the fall and continued even after vaccination. That children were prevented from being present to dying parents, particularly if those parents were dying of COVID-19. And I think the key point is that there is no evidence in our systematic review that any of these policies slowed the spread of COVID-19 in the hospital or in the community. There was no effort to collect the data. There was no effort to study these policies. These policies, of course, conflict with our moral intuition. This is, I think, a huge overreach by public health to do these things. And naturally, we're going to face a severe backlash from trust from the public. Now, one of the reasons offered for why we did this was we had PPE shortage. We didn't have enough masks and we didn't have enough gowns, but we didn't try any other strategy such as modified PPE. By that, I mean, could you have somebody visit a family and then have them take a tablecloth and fashion that into a gown? Could you have them use a cloth mask and then have them go to a hotel and spend a week in quarantine to see if they have the virus? There are all sorts of things we could have tried to both permit people from being present and try to minimize spread. We did no studies. There's no randomized studies. There's no non-randomized studies. No attempts were made. Hospitals, who are most fearful of lawyers, implemented the most draconian measures, and those measures were not questioned. There was no debate at any university that I'm aware of about whether or not it was morally right and scientifically valid to prevent parents from being with their dying child of leukemia. And that to me is a type of excess. That's a type of violation of academic freedom. So I think it's problematic from a moral standpoint, from a medical standpoint. No evidence was generated. If you want to say these things had value, I think the onus is on those people to have generated evidence. They did not. And then nobody held debates on these policies. And they continued post-vaccination, much to my dismay. Of course, I was furious about these policies, and I tried my best to try to stop them. If you look at the evidence base in our paper, you find that the evidence base for these kinds of visitor policies is extremely poor. Cross-sectional surveys, retrospective cohorts, and qualitative research. There's no evidence that I'm aware of that it actually slowed COVID-19 spread, and most of the evidence predates COVID. Okay, vaccines. And I want to be very clear with my position on COVID-19 vaccines, which is a nuanced position. I think in the first quarter of 2021, so January, February 2021, when Pfizer and Moderna had their randomized controlled trials read out on the vaccine, I'm confident that an older person who had never had COVID-19 derived a substantive benefit from vaccination, particularly the first dose. If you're 60 years old in January 2021, you didn't have COVID, I would have encouraged you to rush out and get that vaccine. If you had COVID-19 previously, to date, I'm aware of no credible evidence that there is a further reduction in severe disease or hospitalization from vaccination. Yes, you boost antibodies, but as we've talked about throughout this conference, that is a surrogate marker, and that surrogate has not been validated in the setting of people who have survived the infection of COVID-19. Boosting antibodies does not mean you're less likely to have severe disease down the road. So I think our policies across Western nations that didn't differentiate between people who had and recovered from COVID and those who had not are invalid. Pfizer should have been made to do studies in the people who have recovered. The US never differentiated these two groups. Didn't matter how many times you've had COVID, you still are recommended to get the exact same number of vaccines. At the same time, I think vaccinating young children, particularly children 6 months and 5 years and 8 years, which did not occur in the initial 2021 wave, it didn't occur till much later. I think that was almost entirely misguided. There is no credible evidence I've ever seen that vaccinating a healthy 5-year-old for COVID-19 then improved health outcomes. And I certainly wouldn't recommend it going forward because not only do I not know it improves health outcomes for young children, The virus is a different virus. So I'm not even sure this vaccination program makes sense for young children. And yet the US CDC has added COVID-19 vaccination to the routine childhood immunization protocol. And I think by doing that, they are going to face a huge backlash because people and parents are just going to decline all of the vaccines. And that's what we're seeing in America. By pushing some vaccines too hard in low-risk populations, you will get a backlash. I also think it was extremely problematic in the United States that young college men, 20 years old, who had and recovered from COVID-19 were mandated to get vaccine dose after dose, at least 3 doses at most universities, or they'll be disenrolled from school, even when those additional doses probably constituted net harm because of the risk of myocarditis, outweighs probably the risk of severe disease or hospitalization in that population. So COVID-19 vaccines, my paper is entitled, A History of the Pandemic's Great Scientific Success. It was a success. We've never done anything so fast. That's remarkable, but flawed policy implementation. We pushed it in the ultra low risk populations. That benefits the companies, but it doesn't benefit society. Okay, so the development of the vaccine is remarkable. First dose lowered the risk of death in older people. It has probably zero value for someone who hadn't recovered from COVID-19, very little value to additional doses in young, healthy people. Quickly, it was known to be harmful in young men, and the kids' vaccine program makes little sense. And America is pursuing a perpetual booster strategy. Every year, we're going to get a new one. As far as I can tell, there's just no credible evidence at any age that that's valid. In Europe, typically European nations restrict it to above 50 or 65. But even then, I don't think you know in Europe that if you're 66, you've had 3 doses and had COVID twice, that you actually do benefit from this year's fall booster. I don't think you have that data. So I think even Europe is going ahead of the evidence here. In America, our current fall program is that no matter how many times you've had COVID and no matter how many shots you've gotten, the CDC recommends that any child 6 months and up should get a fall booster for COVID-19, which is simply transferring money to Pfizer and Moderna with no credible evidence generated. So I want to make one point. 2020, before the vaccine was approved, was actually the anti-vax year. Let me read you some quotes. This was when Trump was in office. Quote, this was in Nature. Decades ago, vaccines developed against another coronavirus, feline infectious peritonitis virus, increased the cat's risk of developing the disease caused by the virus. Similar phenomenon have been seen in for other vaccines. And this says, quote, don't rush to deploy COVID-19 vaccines and drugs without safety guarantees. There's an article by Zeke Emanuel and Paul Offit. Could Trump turn the vaccine into a campaign stunt? Quote, even if a vaccine generates antibodies, it does not prove it is effective at preventing infections. It makes it more likely, but serious and rare side effects might be missed. Now, improving antibodies is the basis for a yearly campaign. The rush to create COVID-19 vaccine may do more harm than good. In the British Medical Journal, a weekly effective vaccine can do more harm than good, Phil Krause from the FDA. And yet the vaccine in children between the ages of 6 months and 4 years is only at best weekly effective in the randomized data submitted to FDA. And then finally, Trump's rush for a COVID vaccine could make it less likely to work. So when Trump was in office, media ran story after story about the dangers of vaccines. And in this paper, I've cataloged all of the quotes. And those quotes actually undermine public trust in vaccination. In 2020, according to Pew Research, from May to September, you have widespread declines by age, by education, by race, ethnicity, and gender in would you get a COVID-19? Definitely or probably. And that was done by media, a media campaign that when Trump was in office, the COVID-19 vaccine was considered dangerous, or at least that's what the media said. Now, I think the reason they did that was that people did not want the vaccine to come out before the November election in 2020. If Trump were able to generate a vaccine before the election, it might propel him to re-election. And that's something that nobody wants, particularly people in the academy. And I think that that's reasonable. Trump was on TV and he kept saying that the vaccine is going to come out in October. He kept making these tall promises. And he carried himself like somebody who didn't know anything what he was talking about. He said, put bleach in your veins and all these sorts of crazy. He's always hard to believe when you see him on TV. It's like watching a car accident. Okay. But even though he's bad, okay, in many ways, even though he was suboptimal, the role of scientists should be to not let him affect what we're doing. We cannot let him affect the development of the vaccine. We have to do it because it has a public good. We cannot time the vaccine just for the election because we have a duty to the public. That's what I think science should be about. Doesn't matter what Donald Trump does. But something happened around election day to the vaccine. Let me explain to what happened. Okay, this is something called the O'Brien-Fleming stopping boundary. What does this even mean? When you run a randomized controlled trial, like they did in the Pfizer vaccine study, you randomize 20,000 people to get the vaccine and 20,000 people to get a placebo, it is not the vaccine. And then the primary endpoint of the study is symptomatic SARS-CoV-2, which means you have to have symptoms like a cough, runny nose, fever, and then you swab yourself to see if it's SARS-CoV-2. So the primary endpoint is how many people have symptomatic SARS-CoV-2. And the study is basically designed to say that if you get the vaccine, you're less likely to get symptomatic SARS-CoV-2 than if you don't. In fact, we know that's true. Both studies, Pfizer and Moderna, have 92 and 96% reduction in symptomatic SARS-CoV-2. That was the study. The Moderna study actually had also a reduction in severe disease. Okay, so, but how do you actually do the randomized study? You randomize the two groups and they're blinded. You don't know who's who. And then you're at Pfizer, and every time somebody says they have COVID-19, they swab themselves and they mail the swab to you. They mail it to the central testing facility. And they start testing them. And they say, okay, positive, negative, positive, negative. But they don't know if this person was on the vaccine or placebo arm. And after a certain amount of positive swabs, they say, okay, now's the time for the first look. Now's the time we look first and we see. And they use something like this, the O'Brien-Fleming stopping boundary, to decide when to stop. When you look initially, early on in a study, let's say the first look is going to be after 32 cases. What kind of a difference do you need to see? We have 32 positive cases of symptomatic SARS-CoV-2 in a 40,000 person randomized study. What kind of difference do you want to see before you say, we're going to halt this study? Would you be satisfied with 1715? There's 32, 1715 cases? I think you'd say 1715, that doesn't sound that good. You know, that sounds like kind of like a wash. What about 2012? 2012 sounds better, but it's still within the realm of chance. What about 26.6 or 27.5? Now we say, okay, 27.5, if there are 27 cases in the placebo and only 5 in the intervention, that sounds pretty meaningful. You know, and there's actually a mathematical formula. It's called the O'Brien-Fleming stopping boundary, shown here. This is the Z-score, which is a measure of statistical persuasiveness. And what it basically shows you is that with fewer events, when you look early on in the study, you need a more pronounced Z-score to declare stopping. And as you do more events, the Z-score just needs to be outside of the significant range. In other words, if 10,000 people have COVID-19, and it's 5,500 in the placebo arm and 4,500 in the vaccine arm, you'd say, I bet the vaccine is doing something. But if it's only 2012, you're like, well, that's not good enough. So it kind of makes intuitive sense. As there's more events, the skew needs to be less of a skew before you call it as significant. Okay, this is a mathematical function. In the Pfizer vaccine trial, they pre-specified the times they're going to look. They're going to look at 32 events. They're going to look at 64 events. They're going to look at 100 and some events. And they have a skew pre-specified in the plan. And then they realized something. With the rate with which people were testing positive, they were going to reach 32 events probably in early October. And then they're going to have to test. And if it's 26.6 or 27.5, it's going to be a positive study, and that trial is going to be halted. So many people did not like that idea. And that's why Donald Trump went on TV and said it's going to come out in October, because he had a strong inclination that the 30 events was going to happen in October, probably because Pfizer told him, and he probably thought it was going to be a win. And so they organized a campaign. The campaign was organized to prevent that look at 32 events. And this was covered in MIT Technology Review by Antonio Rigaldo. It says one doctor's campaign to stop the COVID-19 vaccine before Election Day. How Eric Topol tried to kill off Trump's October surprise. And what they did was they took the 32 events and they petitioned Pfizer to submit a protocol amendment to move that event over here to 64. They didn't want the early look at 32. They wanted to have just enough events that it wouldn't occur until after November 6th to delay that vaccine approval. But every time you amend the statistical analysis plan of a study, you actually inflate the alpha error. You're actually creating a big problem, in my opinion. And the skew you need at 64 events is less of a skew. The O'Brien-Fleming stopping boundary is mathematically the same thing, whether you stop early or stop late. It doesn't give you any more statistical persuasiveness because you demand less of a difference between the two groups with more events. Does that make sense? So Pfizer CEO made the protocol change. They delayed looking at the swabs, and that actually resulted in the press releases occurring a few days after the election day. The CEO of Pfizer says, we didn't delay the vaccine results until after the election, just for the election purposes, but there is no medical reason why you would make that protocol amendment. Doesn't make medical sense. It doesn't make statistical sense. They had a pre-planned statistical plan. It was a crisis. They should have looked at 32 events. There's no medical justification other than the fact that academic researchers did not want Donald Trump to get the win. The timeline was based on a plan that called for an outside panel to take a look at the efficacy data for 32 cases, but the companies and FDA later agreed on a protocol change that nearly doubled that number and delayed the review. Okay? Quote, there is no evidence, however, the decision had anything to do with presidential politics, and the companies flat out reject Trump's claims. What people believe is their business. But that's wrong. It has nothing to do with science. The O'Brien-Fleming stopping boundary is clear. By moving the number of events, you actually don't improve the statistical persuasiveness of the trial. So I think the mere act of switching the protocol is a problem. Changes to the plan based on outside information are problematic philosophically. Okay, so I'm going to pause there. I estimate that this is something that nobody wants to talk about. Everyone wants to talk about vaccine hesitancy among the right in America, the Republicans, which they have much of that, but nobody wants to talk about the vaccine hesitancy that was sown by the left when Trump was in office, and this deliberate act of changing the number of events before they looked at the trial, which in my mind has no scientific basis and was only done to delay the results until after the election. And by doing that, I think there is a problem because that winter wave was a huge amount of casualties in America. Had we rolled out vaccination 3 weeks before, we may have saved 40,000 lives. So basically, scientists were gambling with the lives of Americans in order to prevent Trump from being reelected. And I have no problem with preventing Trump from being reelected, don't get me wrong, but I do have a problem with twisting science to serve political purposes and not being upfront about what's going on. Kids vaccine. I think the timeline for I'll skip this for the sake of time. I mean, one point I want to make here is that the kids vaccine has a very problematic FDA approval process. They tried desperately to approve it, even though it had failed a non-inferiority study. They gave Pfizer a third attempt for a third dose, extremely problematic. And we wrote this in 2021 that COVID vaccines for children should not get emergency use authorization. Emergency use authorization is an expedited pathway of the US FDA that is reserved for emergencies. There was absolutely an emergency among adults for COVID-19. There was never an emergency among children between the ages of 5 and 18, between the ages of 6 months and 18. Yes, 1,000 or 1,500 died in America over multiple seasons. That is unfortunately on par with seasonal influenza and does not constitute, in my mind, an emergency. It should have gone through the traditional regulatory approval process, and that would have had a higher level of evidence. And the other point I want to make is that, do I have it in here? The top two officials at US FDA resigned when the Biden administration took over, Marion Gruber and Phil Krause, because they felt that the Biden administration were pressuring them for universal booster campaign. Okay, so some of my problems with the vaccine in the US, the same people who supported repeated emergency use authorizations for boosters based on antibody titers were previously critical of the use of antibody titers when Trump was in office. The press coverage of COVID-19 vaccines pre-vaccine was extremely critical of vaccines. We have news stories where they talked about long-term side effects that are potentially possible. The moment Biden came into office, now they downplayed any concern. Now myocarditis was thought to be overblown. They say the risk of myocarditis from COVID is higher than the risk from the vaccine. That's completely untrue. In the subgroup of young men, it's higher from the vaccine than the virus. And the other problem is that no matter how many vaccine doses a young man gets, he's still going to get the virus. We're all going to get the virus eventually. There's no way to halt the virus. The virus will catch you at the end. So you have much higher myocarditis by getting all the doses, particularly Moderna. The trial had a delay in assessing the primary endpoint, which was done without medical justification, just to subvert Trump. And I think vaccines were debuted in children based on poor evidence and may result in net harm. And vaccines do result in net harm for adolescent men who had COVID. We have a paper in the BMJ Medical Ethics. It's called COVID-19 Vaccine Boosters for Young Adults, a risk-benefit assessment and an ethical analysis of the mandates at universities. And we basically conclude that it is likely net harmful in this age group. I myself was held to a vaccine mandate for the second and third dose, or I would be terminated from my university. I think that was an overreach by the university. Yeah, this is the major figure. The blue and green bar showed you the risk of COVID-19 hospitalization prevented by booster using optimistic estimates. And the red bar shows you the rates of myo and pericarditis from multiple series from the booster in young men. And you can see the red bar is just much bigger than than the difference between the green and blue bar. Very likely, we mandated a medical product on young men that has a net harm. And I think that's severely damaging for public health. We have another paper by Ben Knudsen, who's a medical student in GW, and this is called COVID-19 Vaccine-Induced Myocarditis in Young Men, a Systematic Review. And it basically makes the point that there are many policymakers who say the risk of myocarditis from the virus is worse than the vaccine. But what we find is they often deliberately obscure the statistics. So here, let me walk you through this figure. These look at different estimates of the myocarditis rate per 100,000 people based on stratifiers. What do I mean? Zero stratifiers is like we looked at everyone who got the vaccine and we say, how many people have myocarditis out of everyone who gets the vaccine? And it's like 2.4 out of 100,000. It's like, not so bad. That's low. But that's everybody who got it. But what if you were just to look at 4 stratifiers? Like, let's just look at men between the ages of 16 and 19, and let's just look at dose 2, and let's look at Pfizer and Moderna separately. And what you see is the rates are sky high, much higher, if you look at 2 or 3 stratifiers. In other words, if you combine men and women, if you combine old people and young people, then of course myocarditis looks rare. But if you just focus on young men getting Moderna dose 2 or Pfizer dose 2, it looks really bad. And so this is a way that the old saying, lying with statistics. The proponents of boosting everybody say, well, look at how low myocarditis is. But what they're not saying is that, yeah, it's low because an 80-year-old woman does not have any myocarditis from the vaccine. It's all in young men. Okay, so let's just look at young men and let's treat people differently based on their age and gender and the product. And they don't want to do that. So we have many, studies that actually underestimate the risk because they don't use stratifiers. And that's what we prove in our paper. Mandates. I think this is where public health really made the biggest mistake. We should never have mandated this vaccine. So a few things. One, we need to be very clear on the ethics of mandates. You can only mandate somebody else get a healthcare intervention if that person doing that benefits third parties. For instance, if I have high blood pressure and I take a blood pressure medication, that might benefit me. But if I told you I don't want to take a blood pressure medicine, you can't force me to take a blood pressure medicine. I'm allowed to take risks with my own health. I'm allowed to drink 10 drinks a day and I'm allowed to eat at McDonald's, We don't use healthcare mandates to improve my own health. If we did, then, we might make people do exercise every day and we might come to their house and, confiscate the cigarettes and we might come and, make them eat what we want them to eat, So we don't use mandates typically for personal health behaviors. Mandates are used for the benefit of others. We mandate MMR vaccine because we know if we get a certain high enough, we'll actually extinguish the measles epidemic. We mandate rubella because of pregnant women, So we mandate it for the benefit of third parties. There has to be a benefit to third parties, one, and that benefit has to be so great, the loss of autonomy to the individual is justified. Now, the COVID-19 vaccine never met this threshold. Not only that, we didn't even study it properly. So you could imagine in the initial Pfizer study, if the people randomized on both arms, we took 1,000 people on vaccine and 1,000 people on placebo, and we made their family members swab themselves every day, and we looked at those swabs over time. Then we would actually be able to answer the question of whether or not the vaccine prevents transmissions in households. But that was not required by FDA. They didn't make the company do it. And of course, the company didn't want to do that. So we had never proven that vaccination actually slows transmission. That's one piece of data. The second piece of data, by June 2021, there was a gathering in Provincetown, Massachusetts, a party of many gay men where vaccination rates were in the high 97%. And it had widespread COVID-19 breakthrough in that place. So we knew by the summer of 2021 that no matter, even if you've been vaccinated everybody, COVID-19 can just spread through everybody. It doesn't halt transmission. And so when the Biden administration implemented the fall 2021 mandate, they did it at a time where, one, it was known vaccinated people could transmit. And I think that's problematic. They never had evidence that forcing people to be vaccinated would benefit third parties. And that is a violation, I think, of traditional medical ethics. And this vaccine should not have been mandated, even though I did get it. I think people should be free to choose, but you can't compel other people to do it. And finally, there was a private decision made by the Biden administration, discussed by Paul Offit, whether or not they should give credit to people who had already had COVID-19. And in a private 3-2 vote, the decision was made not to give them any credit. So they have to get vaccinated too. So what you had in America was doctors and nurses and police officers and firefighters who had COVID and recovered, who were fired from their job for not getting the vaccine. And that to me is very problematic. One, because I'm not sure that vaccine dose would help them. And two, I'm certainly not sure it helped anyone else. And so we use the brute force of public health and the police state to fire people for no public health benefit. And I think that that decision alone is going to obliterate public health in the next quarter century. I think there's a growing group of people who recognize that this was an overreach. And I think it's a big problem. Okay, now I just talk about masking for a few minutes and then I'll wrap up. The United States went beyond Europe. They went beyond the European CDC and the American Academy of Pediatrics and the CDC. They recommended that kids as young as 2 wear cloth masks for 10 hours a day in daycare. And those masks were implemented with the power of the state behind it. They're allowed to take it off for naps. Adult randomized controlled trials pre-pandemic showed no benefit to community masking. That's the conclusion of Cochrane. That's the right conclusion. Randomized controlled trials during COVID-19 also showed no benefit to cloth masking. Cloth masking doesn't work in adults, certainly doesn't work in 2-year-olds. I think it's ludicrous to do it in a 2-year-old. I think it's a complete abuse by American authorities. And I think there's only one reason why it happened. Donald Trump didn't wear the mask. And so anyone who doesn't like Donald Trump knows he's always wrong. So we got to wear the mask extra hard. And that's, I think, the basis of the policy. The people on those committees, CDC and AAP, strongly opposed him. And they wanted to go as hard the other direction as they could. And that's taking it down to 2 years old. I implored them many times not to do it to 2. I thought that was the craziest thing I've ever heard in my life. I think Fauci, of course, famous for his mixed messaging on masks. He initially said they didn't work, then said they did work. I think he was telling the truth the first time. That was the consensus of the available evidence. The CDC director went to Congress and she testified that we couldn't have studied masks in kids because there's no equipoise. We know masking children works. We wrote an article in Public Health and Practice where we say, does equipoise exist for masking kids? We almost want to argue that it doesn't exist because we know it can't possibly work, especially for 2 years old. But certainly the mere presence of people who think it does work and think it doesn't work is enough to create equipoise. That is equipoise. The US actually has extended the decision to mask children as young as 2 in high transmission beyond 2023. It's going to continue indefinitely. There's no end in sight. I wrote this article in 2021 at the Atlantic magazine. It was called "The Downsides of Masking Young Students Are Real. The educational cost of face coverings is far better established than the benefits of the mask mandates." And here I'm talking not just about 2-year-olds, but 8-year-olds and 10-year-olds and 12-year-olds. And this article led to a widespread outcry against the Atlantic. And I think hundreds of people canceled their subscription to the Atlantic, angry that this was dangerous misinformation, when in fact it was probably pretty accurate. All right, I'm going to skip that. I want to talk about this study for a second, then I'll make a few closing remarks. This is a study that people cite as evidence that masking does work, and it is in fact a cluster randomized trial in Bangladesh. Unfortunately, it has one problem in it that's such a big problem. This is actually not a randomized study and is not useful at all, and the investigators waste everybody's study time. And it was published in Science magazine. Okay, here's the study. They went to Bangladesh and they took 300 matched villages. They took villages that were the same size as other villages in rural Bangladesh. At baseline, nobody had COVID-19. The villages were matched based on size and a whole bunch of other factors. And then they went to one group of villages and they said, here's a mask, a free mask. We're going to give it to you. And if you have any symptoms of COVID-19, you call this number and we'll have somebody come out to you, or we'll mail a kit out to you, and we'll take your blood and we'll look to see if you have antibodies against COVID-19. So the primary endpoint of the study is you call me when you have symptoms, symptomatic, and we'll measure the seroprevalence, the blood antibodies of COVID-19. In the other group of villages, they go to the village and they ask people, you call me when you have symptoms, but they're not giving you a mask. Okay, so this is the study, a randomized trial of giving out masks and encouraging people to wear masks. Cluster randomized, they're doing village to village. Cluster randomized is much smarter than individual randomized study because people were making the claim that me wearing the mask doesn't protect me, but it protects John from getting it, from me to spread to him. So if you randomize a whole village, you can measure both the spread of virus on the way in and the spread on the way out. So that's why it's a cluster randomized study. It has 4 endpoints in the study. The primary endpoint was symptomatic SARS-CoV-2, what I told you about. The secondary endpoint, which was a much better endpoint, is just asymptomatic SARS-CoV-2. In other words, we randomly pick people in villages and we test their blood for antibodies, and that has no bias. You don't have to call and report. We're just looking at the prevalence of COVID-19 in the population. That's the secondary endpoint. The third endpoint was how often people wear masks. Okay, that's an intermediary endpoint. And the fourth was how often people just complain they have runny nose and symptoms. The primary endpoint, this is the primary endpoint. In the control villages, 0.76% had symptomatic SARS-CoV-2, 0.75%. The cloth mask villages, it's the same number, not significant. The surgical mask villages, they do have a reduction, 11%. So this is why people say community masking works, significant study. But I haven't got to the problem yet. Cloth mask failed for the first endpoint. The second endpoint, the best endpoint, has never been reported by investigators. They've never reported this endpoint in any trial publication, this random sampling. The third endpoint is intermediary, and the fourth endpoint, I think, is just bias susceptible. If you wear a mask, you might report symptoms differently than if you don't. Okay. Let's skip that. Okay. So researchers who looked at this study did this nice reanalysis of the paper, and they found, I think, what's the biggest problem. All right. When you do a randomized controlled trial, there's two parts to it, typically. There's blinding, and then there's concealment. What is blinding? If I randomize you to like olaparib or sugar pill, blinding means that the person who swallows the pill, they don't know that it's olaparib or they don't know that it's sugar pill. So the participants are blinded to the intervention. The doctor can be blinded to the intervention too. The doctor can say, I don't know if this person got olaparib or sugar pill. I'm going to take care of them the same. So that is blinding is about when the study is running, are the participants and the doctors unaware of treatment assignment. Concealment means at the moment of randomization, do you not know which arm you're going into? And concealment is really important because if you don't conceal a randomized study, people may go into one arm more than the other arm if they know they're going to get something, you know? It's a bias that could exist. In the old days, sometimes doctors would hold the envelope up to the light and they could see, is it placebo or experimental arm, and they could pass out envelopes differently. In the modern world of digital randomization, we don't have that concealment problem anymore. This study has a huge concealment problem. The people signed up differently. Okay, let me see if I have it. Okay, so let me walk you through this figure. Well, let me explain it, then I'll walk you through the figure. In one arm of this study, the control arm, 100,000 people signed up to be a part of the study, masking. In the intervention arm, 110,000 people signed up to the study. There's 10% more people signing up in the mask arm than the non-mask arm. And that difference is actually the biggest difference in the whole study. This is a analysis where basically what the authors are doing is they're simulating the study many, many times under the null hypothesis that there's no difference. And they're showing you the symptomatic seropositive rate that they're calling positive is here. You know, it is kind of, it looks like it's, you know, a little bit outside due to, it looks like it doesn't occur all the time due to chance. The rate of any symptoms is out here. It looks like it is pretty significant, like reporting symptoms. But the consenting population size is way the hell out here. It's way different. It's way, way higher in the group that got masks. If I do a randomized study and one arm has way more people than the other arm, why is that the case? It's randomized. The group that got masks, why are they getting an extra 11th person for every 10 people on the control arm? Does anyone have a guess? They what? They moved. No. Oh, okay. Why would they move to the village? Yeah, okay. You got it. But if the answer is because they got masks. Okay, so what they did in this study was when they drive up to the villages getting masks, they pull up in like a big truck with boxes in the back, and they got all the boxes, and they're like, oh, do you want to sign up to my study? And people see all the boxes, and they say, 11 people say, yeah, I'll sign up. When they go to control villages, they come out with a clipboard and say, you want to sign up to my study? And 10 people say yes. But that 11th person doesn't say yes because they don't see a free box of stuff. And so what you have is it's not a randomized study, actually. In one arm, you get 10 people. In the other arm, you get 11 people. And that 11th person is probably a different person. That's a person who only says yes when they see a free box of stuff, and they don't say yes when they don't see a free box of stuff. It's not a random person. It's a different person. And then the question is, does that different person pick up the phone and call you when they feel sick at the exact same rate as the first 10 people? And I would argue no. They probably are not as altruistic. They're probably more likely to do things only if they see a benefit to themselves. They may be less likely to submit to your blood draw for your Western, randomized study. And I think this whole study, the biggest bias in this study is that all of these endpoints can be explained by the fact that it's just a different, there's an extra 10,000 different people in one arm than the other arm. And so I actually think it's an invalid study. It doesn't prove anything to me. And if you were to replicate, we should have replicated this in the United States and in the Netherlands and in UK, we would have gotten at the real effect, which is probably pretty close to null. And I say all this, even if you assume this effect is real, it's almost it's a trivial effect. It's very small. Okay, I'm going to pause there and give you some conclusion slides. I just want to make one point that we published a lot of these papers on COVID-19 policy. During the heat of the pandemic, we tried to put them on medRxiv and SSRN, the preprint servers. Those servers are supposed to post any scientific article. They're not supposed to review it. They're just supposed to make sure it adheres to scientific norms. And the preprint servers repeatedly declined to post our articles, critical of mask mandates, critical of observational studies to justify vaccinating children, critical of confidence interval interpretation, statistical errors by the CDC, that COVID-19 vaccine paper was removed from a preprint server. And they were all removed for the reason that they said they need to be cautious about posting medical content. So we did have, I think, quite active censorship on scientific servers. You could only present one narrative at a time of unprecedented debate and chaos. Okay, I'm going to skip these things. All right, I'm going to give you some closing remarks. My closing remarks on this topic are pretty simple, which is I think that lockdowns was a very bad strategy. I think a lot of people think that. I think it was a violation of Western democratic norms, a violation of traditional pandemic principles. I think there's almost no evidence it actually changed behavior. People were already staying at home voluntarily. Lockdown may have resulted in the police force being deployed on a handful of individuals, but in the grand scheme of population mobility, it didn't change much. I think border closure was horrific. It didn't slow a single variant around the world. It just disrupted travel and commerce. I think everything we did to children was horrific, closing their schools, preventing them from playing, preventing them from having education in the United States, having that prolonged, forcing them to be vaccinated in many districts with a vaccine that has very poor credible evidence. I think that was all atrocious. In the United States, we closed beaches. We took the rims off basketball hoops. We chained off playgrounds. We put sand in skating rinks so people couldn't skate outside. This is all hysteria, irrational fear, did nothing to combat the virus. When we did to get a good vaccine in the United States, we didn't focus on the nursing homes. We gave the vaccine to a 20-year-old resident in medicine. I think that's crazy. In the United States, we deployed it in healthcare workers who are young and healthy, many of whom had COVID-19. And we didn't prioritize the elderly who should have gotten it first. And then the few people who didn't want to get it, we fired them from their jobs when they didn't get it, which I think is a breach of trust in society and in medical ethics. And now we have a system where we're telling people they have to get their 6-month-old vaccinated every year for the rest of their lives. I didn't talk about Paxlovid, but I think the evidence for Paxlovid is terrible. It has no positive trial in people who have been vaccinated. So when you look at the pandemic response, I think the most plausible conclusion is that it was motivated by two things. One, fear. People get very scared, especially when we feel our own lives are at risk. And two, the people who had no advocates, like children, were the ones who were trampled on the most. And then three, the corporations saw a great opportunity to make a lot of money. Pfizer made $100 billion from their vaccines and Paxlovid in the pandemic. And we have not asked them to generate credible evidence that dose after dose after dose is necessary. I certainly think the first dose was life-saving. I certainly will never get another dose again. I think there's absolutely no benefit. I got at least 2 doses against my will, or I would have been terminated by my university. And that to me is a problem. And it was a problem that universities didn't have debates on school closure. It's a problem universities are still not talking about this openly. And I think that the gentleman asked a question yesterday about trust in science. All of the things I talked about with polo and screening and these things pale in comparison to this pandemic. We have a tremendous erosion in trust in public and trust in scientists. That is just going to get deeper in the next 10 years. I don't know how deep it's going to go, but it's going to be one of the biggest societal problems we've ever faced in Western society. I think we should never have used the police state to enforce public health. That's not consistent with the principles of public health. It's antithetical to what public health stood for. We learned from a totalitarian regime in China, and that was a great error in the West. And so how do we recover from that? I think, one, it needs a real accountability. I think what they did in the UK recently is not real accountability. And then it needs apologies, and it needs a commitment for scientists to do science and not to play politics. So those are my thoughts on this topic. Thank you all for listening.
That was a great talk. Are there any questions for Professor Prasad before we move on to Izzy? Professor Dietz?
Professor Prasad, thanks again for your excellent presentation. Just one other remark, I think I would like to have your thoughts on it. Those big companies share their results with shareholders before they're actually shared with scientists, before they can be scrutinized. And then that goes into the press. And then actually the whole momentum is already in place. What's your opinion on that?
Yeah, it's a great question. So whether it's COVID drugs or cancer drugs, the companies control the framing of all the results. They put out a press release. They get their, key opinion leaders on Twitter to amplify that. And I would even go further and argue that many scientific conferences are really held just to let the companies create the narrative. In oncology, we have a recent trial of enfortumab vedotin pembrolizumab, and it got a standing ovation at the conference. Not a single person has read the paper because it's not published yet. So here we have standing ovation. No one can read the paper. No one has seen the data. We've just seen whatever they want to show us. And what happens is people already become entrenched in their ideas. They think it's good and great. And if later you find some big problem with the study, it's harder to change their mind. So I think the current system does allow the companies to shape the narrative around all their products. And one of those things is the press releases they put out to, meet the rules of SEC.
Any other questions? Yes.
Hi, I was wondering, this is afterwards, during the COVID pandemic, what were your opinions publicly? Also, were you vocal about this? Did you do anything then? Because afterwards is easier.
Yeah, after is easy. Did I do anything then? For a long time, pinned on my Twitter was the 210 op-eds I wrote in real time. I wrote op-eds from you can go back and pull it. I have a list on Twitter, but basically, in April 2020, we wrote op-eds saying, let's listen to scientists with diverse viewpoints in stat. And the next month we wrote COVID-19 is a supernova. It's going to affect all aspects of health. Let's be careful. We don't have these problems. By the fall of 2020, I said school closure was a huge mistake. In the spring of 2020, when DeSantis reopened schools in Florida, I cheered him on. But, Fauci actually went on TV and said DeSantis was reckless and playing games with life. And then in the vaccines came out, we wrote the BMJ paper, critical of kids' vaccines. We wrote papers on, so lots of things in real time, lots of op-eds. What was the reaction? I think the hard part is it was incredibly acrimonious. So one thing is I haven't disclosed, but actually my political leanings is I'm on the political left. Actually, I'm a progressive. I was a Bernie Sanders supporter. And to me, what was most painful about the pandemic was that people who I aligned myself with, progressives, we're the ones who should have pushed for kids to stay in school. We're the ones who should have pushed for minority population. We're the ones who should have fought for the underserved. And we were the ones who supported lockdown, school closure, the regressive, brutal policies that you would have expected from the hard right. And so I was incredibly disappointed with progressives because they did it only to thwart Trump, in my opinion. They have no evidence for any of these policies. So I was disappointed. And then I think that when you're a member of the tribe, when you're in group and you criticize the group, you face the worst punishment, which was a lot of criticism. And so, people were upset with, our paper in the Atlantic. And recently they got a talk of mine canceled because they said, I didn't support masking children. That's dangerous. Well, I would say I didn't support masking children because it's unproven, and so, but they got a talk of mine canceled. So I think that everyone who spoke on the pandemic paid a price. Well, even the people who spoke out in favor of lockdowns, I think they paid a price. The people who spoke out against paid a price. I think we have to do better in science to allow people to have argued this. My last point. If Harvard and Stanford had debates and said, we will bring somebody who's pro-lockdown and anti-lockdown, have them debate, it would have made everyone allow them to have some, acknowledge that this is an academic issue. The real failure are the universities, in my opinion. And the reason they fail is the people who run those universities are no longer real academics. For the last 20 years, we have hired people who are just good at business. They know how to grow endowments and get donors to give money and sell their IP to pharmaceutical companies. They are not academics. They don't have real principles. The principles of the academy have existed for 2,000 years. I don't think those principles are in their bones. The Stanford president resigned because his data is all fabricated. You saw that recently. Mark Tesler-Levine, he has many papers with fraudulent figures. He had to resign, a couple of weeks ago. So I think we have presidents who are not scholars. They don't care about discourse, and they have lost the purpose of the academy, and they are chasing corporate profits. And that's unfortunately what universities need to, survive. And that to me means at times of crisis, they do a terrible job, and they did the worst job. So I blame them more than anyone.
Thank you very much, Professor Prasad.